friends, moving on to our next session that will be presented by an eminent nephrologist, Dr. Bismay Kumar. And the topic is a new hope for improved cardiorenal outcome in patients with CKD and type 2 diabetes mellitus. And to chair the session, I would like to invite Dr. Emil Bansali and Dr. B.P. Pandey.
Good afternoon, everyone, and welcome you to Howard Diabetes Society on conference number 7. And probably this topic was the first topic of the day, but unfortunately we have become a tail ender now. We're no more an opening batsman. But this topic and this drug is actually an opening eye and opening drug because it opens up a new hope in managing chronic kidney disease. It opens up a new hope in treating those patients where actually you feel helpless. Now, right from our postgraduate days, when we were doing postgraduate, that the options for chronic kidney disease was minimum. Protein restriction, salt restriction, probably phosphate binders, and we could see them helplessly going for dialysis. But then, things were no more like the same, and by 2001 onwards, lots of studies started coming up in the arena of hypertension, and that where ARB found its role. So RAS blockage and SGLT2 inhibitors came as a big rescue for CKD patient. They had hemodynamic control, better control, they had metabolic control, and there we found that patients were progressing less as compared to previous arena. But it took a long time, it took around 20 years to discover this molecule. From the time ARB was there in the picture from 2001 onwards, and then by all the guidelines saying SGLT2 inhibitor came to 2019. But still, patients do progress. So is there a scope for a third drug? And there the thought process started. Now, this receptor, the mineralocorticoid receptor, is known to us since 1938 and 40s. And from then, the research has been going on this receptor and its viability to use as a therapeutic armamentarium in managing CKD population. So this receptor, I will be referring at it as MR receptors or the mineralocorticoid receptors. They basically they regulate the gene expression through a cofactor recruitment, which includes the multifactorial activation which is happening in renal disease. There is overactivation of MR receptors. And what are the molecules which is working for the overactivation of MR receptors? These are aldosterone, renin-angiotensin converting enzyme 1, cortisol, and many others. So this overactivation of MR receptors leads to fibrosis because there the inflammatory markers comes into play like TNF-alpha, interleukin-1 beta, interleukin-6. All this starts increasing the process of CKD or the fibrosis. So there the thought process started that is there a possibility of a tripod of therapy? One ARB in one arm, SGLT2 inhibitors on one arm, and probably an MR inhibition another arm. Now, I'm taking you a little bit detail of this receptor because if I don't speak about this receptor, probably will not understand the concept of this new drug. Now, this steroidal MR receptor, it's an intracellular receptor. It has various subfamilies. When I say it has various subfamilies, of course, any drug which is working on this receptor will also work on other receptors of the same family. These are like glucocorticoid receptors, the mineralocorticoid receptor which we are actually blocking, the progesterone receptors and the estrogen receptors. MR receptors, basically they are responsible for fluid electrolyte and hemodynamic balance and tissue repair. The glucocorticoid receptors are responsible for energy homeostasis, stress response and inflammation where actually the role comes into picture. And the progesterone receptors are also a part of MR receptors and there where sexual dysfunction is a side effect of drugs blocking these receptors. So now the newer drug, it was discovered in 2009 and it started entering various studies still there. That drug's name is finerenone. Now finerenone is basically, every word is important. It's a novel non-steroidal, selective MR receptor antagonist. In my subsequent slides, I will make you understand what is selectivity of MR receptors. Now, this is a unique structure which results in an interaction with MR and the regulation of a gene expression. And the advantage of this is one, anti-fibrotic property and anti-inflammatory effects. But these are all animal models. There where this study comes from the animal model, we are extrapolating in the newer study which we'll be discussing in my subsequent slides. Now this animal model, also called as DOCA rat model. DOCA rat model is basically a salt hypertensive CKD model. Basically that is deoxycorticosterone acetate model. Now finerenone reduces the mRNA expression of the pro-inflammatory and pro-fibrotic markers in the CKD tissues to a greater extent, which has an equinatriutic effect of eplerenone. And there the effect of eplerenone can be matched with the newer drug using this model, the rat model or the DOCA salt model. And there the thought process came that whether this can be used in phase 3 trial and probably another treatment or another arm of treatment in CKD population. Now to make you understand the differences between a steroidal MRAs or mineralocorticoid receptor antagonist versus this newer non-steroidal finerenone. Now what is the difference? The previous which we are using, I will be mentioning both about spironolactone and eplerenone. Now those were more of, the receptors were more concentrated around the kidneys. That is why we were seeing more of hyperkalemic effect. But the newer receptor, the newer drug which specifically binds to the MR receptor is a balance between the kidney and the heart. So there is a balance maintenance of the receptors between this. So it equally affects both the tissue where it works. And the best part is it is selective to MR receptor. It is not selective. It will not go and bind to other receptors which I showed in the receptor family. And it doesn't have active metabolites and a short half-life, so the side effect profile is lesser as compared to the previous generation drugs. And one of the most important points is it has the other ones which we are using, spironolactone and eplerenone, had a partial agonistic cofactor recruitment. The meaning is it activates the cofactor, that leads to a lot of side effect, whereas this binding is absent in finerenone drug. Okay. So there the advantage of finerenone came over the previous drugs, which is aldosterone and eplerenone. And the most important point, as I have stressed in my previous slide, inflammation and fibrosis. There the mechanism of CKD is coming into picture. So if you have a model which supports this theory that you can retard the inflammation and fibrosis, why not use it in CKD and see? And that was the thought for the further slide. To make the things more easier to you, I have put this tabular form that if you are using the previous generation, it is the receptors are preferential in kidney, whereas if you are using the newer drug, it is more preferential in heart and kidney. Secondly, it has a better anti-inflammatory and anti-fibrotic property, which is finerenone versus spironolactone and eplerenone. Third, the most important point which we are all scared of, that is hyperkalemia. Hyperkalemia chances are higher as compared to finerenone, where it is less when you compare the previous group of drugs. Benefit, the CKD progression. Examples, spironolactone and eplerenone in the steroidal MRA group and finerenone and hexacetonone in the non-steroidal group. Now, I'll just briefly take you through the calendar of events which has occurred right from the insertion of MR receptors. Now, MR receptors, the theory that MR receptor works is known to the humankind from 1938. But it took around 40 years to understand that this can be used in heart failure. In FDA approved the drug in 1960, finding it more cardioprotective. And then it took another 40 years to understand that, to use a trial to understand its effect in heart failure. Today, epinephrine, spinal nocturne is a class A recommendation in patients having heart failure. Another 20 years, but beyond, when we started using this drug, we started understanding its side. It's only when you use the drug you understand its side effects. By 2009, 2011, there were studies which showed its effect as hyperkalemia, especially in CKD population. And then comes a systemic meta-analysis in 2016, which shows that it provides benefit in type 2 diabetes and CKD. By 2019, this was more emphasized in other systemic review and meta-analysis that MR receptors alone or on top of RAS inhibition provides a more anti-proteinuria, that is what you want in patients with CKD. So there were the theory of using this drug into a study, but till now such study was lacking. So today's topic is to talk about that study which involved this drug, which is the Fidelio diabetic kidney disease study or Fidelio-DKD study. So previous evidences we have seen that MR receptors are good in cardiorenal disease, including diabetes and CKD, because it reduces inflammation if you antagonize those receptors, and may work to retard the progression of kidney diseases and cardiovascular dysfunction. Even in meta-analysis, you saw that there was a 31% reduction in the urine ACR, and steroidal MRA data, the clinical hard points were lacking. So you have a proteinuria reduction. So what if there is a proteinuria reduction? Are those patients surviving? For us, the patient comes and asks the doc, I don't want to go for dialysis, sir. Because in dialysis, the life is miserable. So for those patients, are there any drugs, or if those evidences are supporting the evidence that it can reduce these hard points of going into dialysis, of having a cardiovascular outcome? But the most important thing we all scared of again is hyperkalemia. Because of previous experience with spinal nocturne is hyperkalemia. So this study was to hypothesize that finerenone slows the CKD progression, reduces the cardiovascular mortality in diabetic CKD population. So this study, also called as Fidelity, had two arms. One was the Fidelio arm, which was basically more with CKD population, and the second arm was the Figaro arm, which was more with the cardiovascular outcome or the cardiovascular patient having proteinuria. So these were the two articles. It came in 2000 and 2020 and 2021 in NEJM. And this drug this credit to your discovery of drug, this drug goes to this person called Peter Kolkov, who extensively researched and found this molecule for us. Now, in this slide, you can see it is a representation of how the study started. Now, this study had a run-in period. What do you mean by a run-in period? Run-in period is a place where we are actually recruiting the patients, we are actually analyzing the baseline characteristic, and we are using those patients as per our study protocol. So there was a run-in period, then there was a screening period, and then there was a randomization. Randomization was in two arms. One arm was with finerenone 10 mg or 20 mg. I will tell you how the doses were changed. And the second arm was the placebo arm. So Fidelio and Figaro, these were the two arms. The primary outcome of Fidelio was renal. The endpoints was onset of renal failure, a sustained decrease in the GFR from the baseline or death due to renal diseases. And the secondary endpoint was a cardiac outcome. Means what was the primary endpoint of Fidelio was the secondary outcome of Figaro. And what was the primary outcome of Figaro? Because the primary outcome of Figaro was more using the data to analyze the cardiac benefit. Fidelio was using the data to analyze the renal benefit. So this flip-flop, the secondary endpoint of Fidelio was cardiac, to analyze the cardiac benefit, and Figaro was again the renal benefit. And there were other endpoints which analyzed all-cause mortality, all-cause hospitalization, change in urine ACR, and the time of occurrence of the kidney failure. Now, I'll just briefly tell about this design. Basically, we took patients beyond age of 18 having microalbuminuria. Microalbuminuria is basically urine albumin creatinine ratio more than 30, and we used the GFR above 25 and below 60. That was the GFR taken with diabetic retinopathy. So these were the population which were included in the fidular trial. What we excluded? We excluded non-diabetic kidney diseases. We excluded uncontrolled hypertension. That was the important point, and probably that was another point for disadvantage of the study. Third, we removed heart failure, we reduced ejection fraction, because in those patients, spironolactone is a class 1 recommendation. So that is why that was excluded from this group. Recent cardiovascular event, and any patient who needed dialysis, or there was sudden rise in renal failure or acute and chronic renal failure, and patients going for transplantation, those patients were excluded. So there was a running period. These patients were mandatory run through a period of 4 to 16 weeks to analyze the hypertension control, diabetes control, using the ACE and ARB, because of all those patients, this is a very important point, all those patients were on ACE and ARB at the maximally dose tolerated. What do you mean by maximally dose tolerated? Not that we use the highest dose, no. The dose of ACE or ARB which patient could not throw any symptoms or side effects to ACE ARB, that was the maximally tolerated ACE ARB as per the guideline of the manufacturer. So that was the dose which were used. First they were put on ACE ARB, hypertension was controlled, and then they were randomized and they were thrown into two arms. Finerenone started with 10 milligram and then escalated 10 milligram to 20 milligram after a period of 1 month. So this was a phase 3 trial, randomized, double-blind, placebo-controlled, and 42 centers were involved. So it was a multiple clinical trial. Obviously, it was a sponsored trial by a company, and age, as I told, it was more than 18 years, urine ACR more than 30. Potassium, what we took over here was less than 4.8, because because there's no point in starting a drug and suddenly hyperkalemia occurs and we stop the drug. So the study is meaningless. So we took a lower threshold, 3.5 to 4.8, and we gave a room of improvement. Once they crossed 5.5, that was the reason where we had to stop the drug, and we reintroduced this drug after 4 weeks if the hyperkalemia got controlled. The management of hyperkalemia was totally the clinician's discretion who was looking after the patient, and we saw this patient at month 1, then 4 monthly, and till the trial ended, every 4 months this visit was done. Figaro, again the same thing. The difference between Fidello and Figaro trial is Figaro used a higher GFR. Now even the GFR of 90 was included in this study, and proteinuria was lesser as compared to Fidello. So Fidello had more high proteinuria patients, and Fidello had even highest microproteinuria patients were seen over here. And the benefit was analyzed according to the cardiac benefits. So the difference between these two is basically GFR. We took higher GFR and more microproteinuria. Pronounced proteinuria population was there in Fidello trial. So what was the sample size? Is the sample size enough? Now if you compare this study with the previous studies which we have seen, the renal, the IDT, the credence, the TAPA-CKD we all talk about, the EMPHA kidney we all talk about, probably this was the highest numbers we have seen. The total number, if you compare the total number stood around 13,000 plus patients, 5,000 approx in Fidelio and 7,000 population approx in Figaro trial. So population was the highest number of sample size till whatever studies we have seen in drugs used in CKD. So what were the baseline characteristics? Baseline characteristic, one was the age. Age was taken as around 60-65, because these are the groups where the highest number of CKD population comes from. Mostly more male-dominated patients, and second, they had a hypertension which was controlled. Now this point is one point you can actually favor and also disfavor this study. Then HbA1c was controlled. These things were maintained in the trial, in the screening period till the randomization occurred. We make sure that hypertension and diabetes was under control. So these were the various comorbid factors of this patient. GFR in Fidello, the average GFR was 44. Figaro, it was higher, 67. And urine ACR we saw high in Fidello study as compared to the Figaro study. Then using the drugs which was already there with these patients, GLP and SGLT2 was least number of patients. There is a point where you can say that the effect of SGLT2 inhibitor was not there in this patient, because it was just 7% or 4 to 8% if you compare SGLT2 inhibitors or GLP-1 receptor agonists. So these are the drugs which were kept at a lesser number in these populations. So if you see the baseline characteristic of this patient, the study period was around 2.6 years in Fidelio, and Figaro is 3.4 years. 98 to 99% patients were on maximum tolerated ARB. That is another important point. And the adherence was excellent. 92% in the Fidelio group and approximately same in the placebo group. So what was the outcome? So if you see the outcome, on top of maximum tolerated RAS inhibition, finerenone significantly reduced the primary kidney outcome by 18%. You see the graph separating at 6 months, 12 months itself, that finerenone showed a better survival as compared to placebo. Numbers to treat for 3 years to avoid any CKD outcome was around 29. And if you see the kidney failure, the end-stage renal failure, all favored the finerenone group versus the placebo group. Talking about the urine ACR ratio, definitely it was better as compared to placebo. There was approximately, if you see, 31% reduction in the urine ACR right from the time we started using this drug itself. And what about the secondary CV endpoints? 14% was the reduction in the CV endpoints. The graph starts from the beginning itself, you see the difference between the placebo and the finerenone group. And so CV composite outcome was definitely better with the RAS blockage. And the most important point, these patients did not require hospitalization. Hospitalization of heart failure was minimum with finerenone group. In Figaro also the renal outcome was better. You saw more than the accepted, when we talk about doubling of serum creatinine or doubling of GFR, it basically means that around 50% decrease in the GFR that was found less in finerenone group as compared to the placebo group. But the most important point which is coming in our mind is the safety concern. And the most important part of the safety concern will be the part of the discussion is the hyperkalemia. So if you see the hyperkalemia data, it is almost same, but it is higher in finerenone group as compared to placebo group. But if you see the hospitalization because of hyperkalemia or death in the hyperkalemia was very less. Approximately the discontinuation of the trial regime or because of hyperkalemia was as less as 1% or 0.6%. So this is a list of adverse effects which you can see. So hyperkalemia, all around safety concern, the side effects were higher with finerenone, but hyperkalemia requiring hospitalization or causing a serious adverse event, leading death was almost 0%, and it was just 1.4% as compared to the placebo group. So safety concern, obviously finerenone had a modest blood pressure control around 3 to 6%. HbA1c and body weight were similar in both groups, so that didn't have any advantage. And there was no difference in the acute kidney injury between these groups, and side effect profile was also rare in the finerenone group. So finerenone, actually, if you talk about hyperkalemia, the mean increase in serum potassium was just 0.2 millimoles versus placebo group. So, and that also was some hyperkalemia was managed temporarily by withholding the finerenone, and it was a manageable hyperkalemia. So, if I have to put in one slide both the studies, we are comparing a CV composite outcome, which is the CV death, not fatal event, the MACE, and the kidney outcome, and the baseline characteristic of both. If you compare, then one thing is important, that when you are using Fidelio trial, you are seeing patients with more proteinuria, with lesser GFR, and when you see Figaro, you see higher number of patients with higher GFR. So if you see that entire study states that there is a reduction in the CV composite outcome and also reduction in the renal outcome. So an important point is, one, you have seen that SGLT2 inhibitors were only 6 to 7%. But have there been some subgroup analysis in the 6.7%? We saw that definitely it has a better control of proteinuria if you use it with SGLT2 inhibitor, but that influence was minimized to give you the value of the proteinuric, antiproteinuric effect of finerenone. So Finerenone reduced cardiovascular morbidity and mortality by 14% in Fidelio trial, and Figaro trial, it reduces the risk of CKD progression by 23%. So now, hearing to all this, the one question which comes in the mind, that in whom shall we use this drug? So as per the ADA update, June 2022, the patients with CKD who are at increased risk of cardiovascular event or CKD progression are unable to use SGLT2 inhibitors or non-steroidal MRA, recommend to reduce, finerenone can be recommended to reduce the CKD progression and CV event. And the recommendation on cardiovascular disease and risk management also the patient with T2DM and CKD, maximum tolerance of ARB is already on board. Finerenone can be a second drug for you for managing better CV outcomes. Even in India, DCCI has approved this drug to be used in CKD population with type 2 DM. So, little bit about pharmacology. If your GFR is more than 60, you can start with 20 milligram once a day. And if it is between 25 to 60 GFR, you can start 10 milligram and slowly you can build up to 20 milligram, watching the serum potassium values. In less than 25 GFR, it is not recommended. And if your potassium is rising, no worries, you can just withdraw the drug, watch for the settling of the hyperkalemia and restart at lower doses. Contraindication, some drugs you have to be careful, like itraconazole, ketoconazole, ritonavir, and in addition disease where already the MR receptors are less active, you need not block those receptors. So the key point is MR overactivation can be another therapeutic aim for us in the future for managing CKD population. Finerenone is a good proposition, novel non-steroidal selective MRA blocks MR overactivation, and finerenone slows the CKD progression. We have seen in this study, so that's an added advantage. Fidelity, which includes Fidelio and Figaro trial, has shown that effective investigation and treatment option for cardiovascular and kidney protection. What are the points which are not favored in this study? That's also an important point for us to highlight. Now, this duration of this study on average was 3 years, but we see this patient to go along beyond that. So we don't know what will happen beyond that. So probably the duration of study, we'll understand what happened to this subject when the further analysis come. Secondly, we are already having a patient with a controlled hypertension, with BP 130/80, with controlled sugar of HbA1c around 7. So we are not seeing the rough part or the difficult part of the CKD. So that may be one point which is also a disadvantage. Age was around 60, but newer patients which were coming this year, as per the SEEK study, which was conducted to understand the epidemiology of CKD in India, the CKD population, the mean age is reduced to almost 50 to 45. So probably we could have more younger population in these patients. CKD5 and advanced CKD was not part of this study. Non-alcoholic CKD was not there, but that's understandable. All those studies which is there in nephrology have proteinuria. So probably that was the reason there were non-alcoholic patients were not in this study. It was a placebo control, so we don't know, we don't have any hard evidence on a head-on trial with epinephrine. That could have been, or a subgroup would have been better. Hypertension was already controlled. We didn't have any data on hyponatremia, which is a side effect of this drug. And most important, this is in phase 3 trial and a sponsored trial. So probably those may be a disadvantage for using this drug. So if I have to take the point of the day, probably I would recommend that we can start to use in affordable type 2 DM-CKD patient who are having increased cardiovascular risk, worsening albuminuria and renal function despite having good dose of ACE/ARB in a normal kalemic patient with appropriate follow-up. That is the most important point. So I'll come with some hardened realities. So practicing in India, practicing in our population, the challenges are different. We have patients who can hardly afford other medicines. I just found out the cost of any medicine as per date. I found that almost a non-dialysis CKD population, if you talk about hypertensive, OHS, insulin, erythropoietin, iron, soda bicarbs, cardiac medicine, dietary supplement, investigations almost comes to around 5,000 to 21,000 rupees per month for these patients. So probably this is the hard reality. We have to take everything with a pinch of salt. Whether we can use this drug in this patient, whether they can afford this drug, is that advantage of using this drug? That may be the question to be answered in the future. Probably this study was in a calm sea. I mean, probably there was no normal hypertension, there was no uncontrolled sugar, but that's not the case with us. We always have to handle rough seas, rough patients with uncontrolled hypertension, 200, 210, HbA1c 10, 12. That is how a patient comes. Probably we don't know its role in such rough situation. So probably this will be answered by this trial. Some are there in the pipeline. This study is in phase 3. The results are there in front of you. Probably there are other studies which have been awaited, and that will show the light of the day. Thank you very much. And my disclosure is basically this session was sponsored by Bayer Pharmaceuticals, and my sincere thanks to Camellia, Arindam, Tanmay. They helped us a lot to conduct this program and help me with this presentation. Thank you very much.
So, can I ask you one question? In a diabetes patients well controlled with a diabetic nephropathy, we know the Credence trial had 30% event reduction. This trial has approximately 18%. So if you have to choose between the two, you'll use SGLT2 or these non-steroidal MRAs?
So if we have to choose in between the two, SGLT2 has been there in the market for last 5 years or so, and we are using this drug for longer. Probably in that situation, I'll prefer SGLT2. But this is a third tripod problem, just what I was speaking, that it may be a third armamentarium where SGLT2 is difficult to use. So there this finds a space. Even if you see in those sub-analysis, that 6.8% of patients who are getting both SGLT2 inhibitors and phenylenedione, they had 35% reduction in urine ACR as compared to 30% with only phenylenedione. So if you use this as a synergistic effect, probably we will have a better proteinuria, but these are speculation we may see in further studies.
In diabetic kidney disease, can we use RAS blocker, AC inhibitor or ARB plus SGLT2 inhibitor, and this latest non-steroidal MRA, phenylenedione altogether? Because in 5% of cases in Fidelio trial, there were SGLT2 inhibitor, and at that time SGLT2 inhibitor, there were no trial report that it is beneficial for renal diseases. Now we have got enough evidence, so we can combine all the three molecules. And regarding hyperkalemia, SGLT2 inhibitor will rather reduce the hyperkalemia induced by phenylenedione.
I'll beg to differ on this point because SGLT2 inhibitors with phenylenedione, with this, we don't have enough data to answer this question. Only data which we have right now is from this trial, which is giving a population of around some 100 or 150 odd patients. But probably in the recent, another trial is coming up, which has compared EMPHA with phenylenedione and a ARB versus EMPHA, placebo and ARB. There this answer will probably come in few days, but as of now we don't have an answer. This is a speculation that possible this may be a third armamentarium to treat this patient. Going by the small subgroup analysis, but one thing is important, that these all drugs work separately. They don't work synergistically. So if you want to take that this will work with that drug, it's incorrect. They are all working in a different way. Together, their response, then we have to wait for this newer trial to come.
So if there is, yeah, Dr. Somani, please.
I have one comment to make. First is that the pre-introduction by Dr. Bismay. Whenever a new molecule comes, there is a great surge of interest in that molecule. We'll have to wait for a couple of years before the actual side effects profile appear. Let me remind you, when thalidomide first came, there was huge interest in it. But when congenital disorders, phocomelia, etc. came, the interest died down, and people used to say, I won't give it to my dog. Later on, it was found that thalidomide is indicated and drug of choice in some conditions such as leprosy excellence. So we'll have to wait for some time. Cost is certainly prohibitive.
Thank you.
As
So we will close the session. I think we are running behind. Thank you, Bismay, for a wonderful presentation. Thank you, my co-chair.
Thank you so much, Speaker. Thank you, Chairperson.